Since COVID started, the economy has begun to recover. GDP is up, people are traveling, and employment is rising. But it still doesn't feel quite right. We continue to see empty store shelves and help wanted signs that are never taken down. We have become a shortage economy that is similar to the 1970s, when energy shortages caused long gasoline lines. Also like the 1970s, inflation has started to soar again. It is already up 7%. We see this inflation at the gas pump as well as at the grocery store. Having a strong labor market is just one out of many necessary conditions for the supply chain to improve and to allow both the Social Security and Medicare hospitalization trusts to get enough payroll tax revenue to avoid insolvency. This chart depicts the labor force participation rate and the employment to population ratio for all Americans starting from 1991 to the present. The gray bars represent the recessionary periods. It's important here to note that the last recession was extremely short-lived and is the first recorded recession that was started by a disease and not an economic factor. It's also important to note that while the COVID recession was the shortest in history, it has been the most disruptive since the Depression. The green line is the labor force participation rate. It measures the supply of labor, of people who are either working or looking for work. The orange line is the employment to population ratio. It measures employer demand. It also is a measure for the payroll tax base for both the Social Security and hospitalization programs. The gap between the labor force participation rate and the employment to population ratio represents the share of unemployed or the excess supply of labor. The area above the labor force participation rate represents those who are not supplying their labor to the labor market. Here we mostly have school-aged children and retirees. The first thing to notice is that both the labor force participation rate and the employment to population ratio have been declining since the 2001 dot-com recession. Many surmise that the baby boom generation turned 65 in 2010, and a lot of this decline can be explained by the retirement of baby boomers. But the baby boomer retirement does not tell the whole story. This chart depicts the labor force participation rates and the employment to population ratio of individuals 65 and up, the senior citizens. Up until the COVID recession, the labor force participation rates and the unemployment to population ratios were rising. Since the COVID recession, there has been an exodus of senior citizens from the labor force. Yet, retirement does not explain the drops before the COVID recession. One reason that the senior labor force participation went up before COVID was probably due to underfunded retirement plans. After the COVID recession, public equity markets appreciated so rapidly that many found the opportunity to find retirement. This chart depicts the labor force participation rate and the employment to population ratio for Americans aged 25 to 54. This is not and should not be the age cohort where retirements occur. Yet even here we see declines in both the labor force participation rates and the employment to population ratio even before COVID. Even though the economy was growing after the COVID recession, the labor force participation rates and the employment to population ratio have not even recovered halfway for this 25 to 54 age cohort. This is the major malady in our labor markets. In this presentation, we give some insights behind this malady. The orange line in this graph represents the number of unemployed in the United States. It spiked around the 2020 COVID recession. The yellow line depicts the number of job openings. Today, we find that the number of job openings exceeds the number of unemployed. This is another major malady of our labor market. So, in this presentation, we address two major maladies of the labor market. The first malady is, why are so many individuals between the ages of 25 and 54 not fully employed? And two, why are the job openings not being filled with the currently unemployed? For question one, the public news media at best has used summary statistics and has used the following conclusions. Some conclude that people are too scared to go back to work for fear of contracting COVID-19. Others conclude lack of child care. The third big conclusion is COVID burnout. Fourth, disincentives to work from the COVID stimulus payments. 5, wages are still too low to induce people to go back to work. For question 2, about the unemployed filling the job openings, the public news media can only give a skill mismatch between those looking for work and those who are hiring. Obviously, there's a skill mismatch. Obviously, the unemployed do not have the qualifications to fill the current job openings, but we need to dig deeper and know why. Unlike the major news media, we go and use microdata to get insights rather than summary statistics. There is some evidence to the argument that wages need to rise to induce more to come back to work. The yellow line on this graph represents the yearly growth in wages, and the orange line represents inflation over the past 20 years. It is clear that at most times, wages have barely kept up with inflation, which means workers have barely been keeping up with purchasing power over time. Even though wages have recently risen, inflation rates have risen even more, punishing workers with a severe loss of purchasing power and providing perhaps an inadequate wage to get workers back to work. Presently, both prices and wages are growing. When this happens over a long period of time, we get into a wage-price spiral where we get into a nasty feedback loop as wages rise to compensate for rising prices and prices rise to compensate for rising wages. It is tempting to control prices so that wages can keep up. It has been tried in the past and did more damage than good, because the control of prices is merely treating a symptom and not a cause. When President Nixon imposed wage and price controls in 1970, a battery of destructive events occurred. Farmers had to drown their chickens because the losses incurred from feeding them outweighed the cost of destroying them. Employers had to let employees go because they could not adjust their prices to cover costs. It wasn't until the late 1970s that the wage-price spiral was broken by the Federal Reserve under the leadership of Paul Volcker, ending the primary cause, which was excessive monetary growth. The Census Bureau Household Pulse Survey estimates that out of the 59 million non-retired individuals who are not employed, 7.6 million were caring for children. Now, some of these may be doing this as a choice and not because of a lack of access to child care. There are two basic reasons for lack of child care. One, it's too costly, and two, there might not be any child care facilities in the local area at any price that has an opening. The child care issue is not new to the pandemic. Rather, it started in the 1980s as more and more women joined the labor force. The current proposed Build Back Better America bill has provisions to limit eligible family payments to 7% of income, finance quality improvements, and to help supplement child care worker pay to induce more child care workers to work at facilities. On the surface, this seems to be a comprehensive proposal that addresses both the supply side and the demand side. However, there could be unintended consequences. The subsidy to households could increase the demand for child care, while the subsidy to wages could increase the supply. But the demand impact could far exceed the supply impact, increasing the number of parents who cannot find any access to any eligible child care facility. This in turn could make child care more unaffordable to many parents, as they would be forced to pay the full cost of ineligible child care alternatives that have substantially less quality. It could be the most vulnerable parents that would be the most adversely affected. What does the microdata say? We ran a variety of multivariate models that estimated how demographic and health variables impacted employment status, and how demographic attributes predicted the probability of being in a certain industry. We found that having an occupational certificate or license greatly increased the chances of being employed. Yet for 2021, we found a decline in the share of workers who had these certificates or licenses. Vo-Tech training has a higher rate of return on average than a four-year college, even though some statistics show on average college graduates earn more than Vo-Tech graduates. The factor that makes Vo-Tech return a higher rate are the far lower monetary and time costs. Vo-Tech graduates also do not have nearly the same amount of debt that college grads do. Not all college grads out-earn Vo-Tech grads. There are cases where one can earn more by going to a Vo-Tech school rather than a college. Finally, there are a limited number of Vo-Tech training programs, and this will create a shortage of electricians, plumbers, welders, and other trades. Families with children are declining, and in the future, childcare will be less of an issue. There is a feedback loop between health and employment status. Poor health lowers the ability for one to be gainfully employed, and in turn, lower employment ability inhibits one from living a healthy lifestyle that includes gym memberships, recreational activity, as well as routine health and dental checks. On this page, the top graph shows the distribution of job openings by industry. The bottom graph are the results of our multivariate model that predicts the industry where each unemployment individual would be most proficient. The healthcare industry has the highest number of openings, and also the most number of unemployed who have their highest proficiency in healthcare. Then the question becomes, why aren't the unemployed filling these job vacancies in the healthcare sector? The answer is that there's a multitude of healthcare entry barriers. Now, in many cases, entry barriers do protect patients from incompetent professionals in faulty facilities. But in the case of healthcare, the barriers also listed here have prevented employment for many who would have made great physicians, nurses, medical technicians, lab assistants, nurse assistants, and even medical billing specialists. Statutory barriers reduce patient ability to self-care and stymies competition by not allowing alternative medicines and occupations. There are a wide variety of regulatory barriers, and the self-regulation in healthcare makes matters even worse. The financial crisis has taught us that self-regulation does not work. The rules of entry in healthcare are based more on the attended institutions rather than based on what one knows and what one can do. There is no incentive for bodies responsible for accreditation to mitigate medical professional shortages. The Liaison Committee on Medical Education accredits medical schools. It is led by MDs. The parent organization, the American Association of Medical Colleges, projects a shortage of physicians of between 40,000 and 124,000. Yet nothing is being done. Many school graduates are not placed in residency programs. When this occurs, the unplaced MD graduate cannot practice, and their time and money spent on medical school goes to waste. Less expensive and more inclusive alternatives, such as online learning, have not been implemented. The financing obstacles for all types of medical training prevent many from pursuing a healthcare degree or certificate. Our high schools and college education structures do not provide adequate pre-medical training opportunities for many students. The first 5 barriers are more acute for minority cultures and races, making them underrepresented in the medical system. This ends the presentation. Unlike any other developed country, there is a declining labor force participation rate among the 25 to 50-year-old age cohort in the United States. This creates greater supply chain problems, a greater inability to find basic services such as health care, and threatens the solvency of both the Social Security and Medicare trust funds. While COVID fear, child care, wage inadequacy, stimulus payments, and maybe even burnout if it could be measured, all play a part, the key missing ingredient, which is a cause, is worker training programs. The currently unemployed do not have adequate access to training that would make them employable. The healthcare industry has the largest number of job openings and is the industry in which most of the unemployed is proficient in. The labor force participation rate would rise if the unemployed had access to adequate healthcare training. Yet the current and regulatory framework for healthcare training provide little incentives to develop better, more affordable, and accessible training programs. Entry barriers for healthcare providers also destroys many employment opportunities. There needs to be a redesigned way for regulation to protect patients rather than professions.